Welcome everyone to this small scientific session which we have organized on behalf of Department of Neurosciences. Today is 26 March. Today is Purple Day, and this day is organized as Epilepsy Awareness Day internationally. As a team, as a neurosciences team, we have begun a small baby step towards helping out patients with epilepsy, which requires interdisciplinary teamwork. So I'm very glad that today, on this day, 26 March 2022, we are starting an initiative which would impact and help a lot of patients with epilepsy and its associated disorders. The branding team, the marketing team have created this beautiful logo which sums up the entire event today. We need hands. We need hands that can join, which can come together and create and raise awareness about treatment and remove all the social stigma and other things which are associated with epilepsy. Epilepsy is a huge problem. We don't realize it, but more than 50 million people worldwide are known to be suffering from epileptic disorders. The numbers are so huge that if you combine patients with multiple sclerosis, cerebral palsy, MD, and Parkinson's disease, all of them combined together, that also number will fall short of this 50 million mark. In India itself, there are 12 million people with epilepsy, and most of them, 80% of them, do not have an access to proper management, diagnosis, and surgical treatment. Our data shows that roughly about 200,000, that is 2 lakh people, can actually be cured by surgery or by other things. However, only about 1,000 patients have an access for such a facility. So Purple Day was started by the initiative of this girl, Cassidy Megan, in 2008, at age when she was 8 years of age. And her goal is to remove the stigma of epilepsy and remove the myths and discrimination which associated with patients suffering from epilepsy disorder. Any guesses? Who is this gentleman? Any show of hands? Anyone can guess? All right, this great man, I will reveal the name later on. He had epilepsy throughout his life. And this is what he describes when he used to have these epileptic fits. I scarce could muster strength to drain the beast, and the convulsions that followed, till I gasped upon the brink of nothingness. And this nothingness, isolation, and inhibition leads to a lot of problems in patients with epilepsy. And he was no other than Alfred Nobel. And I'm sure that all of us, especially from medical background and scientific background, knows what the importance of this man. So today's session basically would be to connect each other. They say good things start at home. This is our family, this is our home. We are embarking on a journey today, and we would want the support from all of you to support this mission. So let's talk, support, and join us so that we can change a sad face to happy face. I will introduce Dr. Bindu first to come over and deliver her first talk on impact of epilepsy.
Good afternoon to each and every one of you. I will just give a glimmer of the impact of this dreaded disease in the people. You might ask, what is epilepsy? It's a chronic condition in which you get more than 2 unprovoked seizures. And what are seizures? Seizures are sudden, uncontrolled electrical activity between the brain cells causing change in the behavior, sensation, abnormal movement with or without awareness. It can be any of this, not always due to abnormal movement. It can start at any age. be it a child or an elderly. Causes? Very many. Starting with congenital malformations of the brain, any perinatal hypoxia, genetic causes like tuberous sclerosis, infections of the brain like tuberculosis or neurocysticercosis, stroke, brain trauma, tumor, and metabolic causes. Despite sometimes after extensive investigations, still the cause will be not known, in which case we call as idiopathic. When we talk about the prevalence of epilepsy, it's the second largest chronic neurological disorder globally, the first being stroke. The good thing about it is that 70% of these dreaded diseases is fully treatable. Mind you, fully treatable. But the sad thing is that 7 out of 10 people with epilepsy do not get treatment. Why? Could be due to that they're not aware. I told you that seizures can be just abnormal sensations. They're not aware that that is a seizure. And that's the importance of this epilepsy awareness program that we conduct today. There is no training personnel, especially in low-income countries, no doctors, no trained person to find out that disease is epilepsy. Then social stigma in a country like India, it is playing a major role. Last but not the least, because of less cost, not affordable, people don't seek treatment. The main things that impact the quality of life is the disease itself. Because of the severity and the increased frequency of the seizures, they are not having a good quality of life. The comorbid psychiatric conditions like depression, anxiety, which is very much common in these kind of situations, because they have to live with a disease which is never ending according to them. I told you, according to them. Then the comorbid medical conditions, diabetes, hypertension, obesity, dyslipidemia, and so on. Last but not the least, the social stigma. The stigma that the epilepsy is due to a ghost hidden inside that patient. The stigma that it is due to madness. This is another slide which just reiterates the earlier thing. That is, the impact is not just personal alone, but also contributed by the society. Personal, because of the disease, your comorbid conditions, your psychiatric comorbidities, etc. But he is living in a society where he has to interact with the partner and the family members, friends and the peer groups, and the society at large. So the attitudes towards the people with epilepsy has to change. And we all, being medical personnel, has got the responsibility to change at least the social stigma so that people can come forward to get the effective treatment. The goal of any treatment measure of any disease is freedom from that particular problem, and so do with epilepsy. So the anti-seizure medications are the mainstay of treatment, and if the person is not responding to anti-seizure medications more than 2 with maximum tolerable dose, then we call it medically refractory epilepsy. And in this kind of situations, we resort to surgical excision of that part of the brain, which really is the genesis of epileptic focus. In certain conditions, we are not able to find out where the seizure comes. The whole brain is epileptogenic sometimes. That we call as epileptic encephalopathy, especially in children. There are diseases like Lennox-Gastaut syndrome, in which case we can stimulate the vagus nerve to decrease the seizure emission. That is called vagal nerve stimulation, VNS. There is a special diet called ketogenic diet so that we can decrease the number of seizure episodes. And today, being the Purple Day, celebrated all over the world, we also want to make every one of us aware that epilepsy is a treatable disease and we can also embracing a culture of teamwork and excellence in service in MIOT. I think with support of each and every one of us, we can go a long way to fight against this disease. Thank you. Now I invite Dr. Shankar Balakrishnan, who will be talking on the topic medical management of epilepsy.
Good afternoon, everyone, and this is a wonderful opportunity to talk about epilepsy medical management on World Epilepsy Awareness Day. So when we talk about epilepsies, more in the society it is different, in the families it's different, and when it comes to the hospitals it's completely different. So what we see as epilepsy may not be seen as epilepsy in a family. They consider it as a social taboo. And in some cases, the epilepsy will be very benign, means 1 to 2 episodes a year. And in some cases, the intensity will be very high. The patient may be getting seizures almost every day. So looking at the pathophysiology of epilepsy, which is very important in treating, it's all about the balance between excitation of the nerves and the inhibition of the nerves. So when the balance goes off, patients can have a generalized tonic-clonic seizures. And in pediatric age groups, it's very difficult. The baby will be just staring for a second, withdrawn from the environment. And then the family will not be able to understand what is happening with them. And now the epilepsy, like previously it was classified as 2 episodes. Now we don't need to wait for 2 episodes. 1 episode with a high risk of another event identified with EEG, MRI, or anything. So if there is an increased risk, then 1 episode plus an increased risk, we classify them as epilepsy, because it indicates that yes, we need to address at the earliest possible. So what is happening in the brain, in the surface of the cells? So we do have channels to regulate the movements of ions in and out of the cells, which is very important in the brain. Each electrical activity is responsible for the normal functions of the human brain, but they are like the waves of the sea. But when there is an abnormality happening on the surface of the cells, especially when these channels, when they are not able to close as soon as a sufficient number of ions gets into it, then they generate giant waves like tsunami, which destroys everything, which spreads to the other part of the body. And when it starts at one part and then spreads to the other part, it's called as partial seizures. As only one part of the brain is abnormal, and it is transmitting the abnormal waves to other part, and wherever it goes, it produces symptoms according to it. We call it as Jacksonian march. And when it is arising from every part of the brain or multiple part of the brain simultaneously, then it is called as generalized, means this abnormal electrical activity is happening all over the brain. They manifest with tonic posturing, they lose the tone and suddenly fall, or it could be a tonic-clonic convulsions, it could be absence, or it could be a myoclonic when it is generalized in onset. Why we need to classify this? The treatment differs. Some of the medications which are compatible with partial seizures may not be compatible with generalized seizures. That's why we need to classify them. And when we look at the classification framed by ILAE, it also involves a prognostication. The classification is important for prognostication purpose. So when someone says it is an epilepsy syndrome, it indicates that it's not something simple. We need to keep the child under follow-up. So syndromic childs, they do very bad with management of epilepsy. So when we identify syndromic epilepsy, we need to put them on a track. Like motivate them. So tell them what are all the options available. They may try medicines, and if they fail, they may not come back to you. Tell them that there are a lot of options available even if the medicines fails at the beginning itself, so that the family will get prepared for what they are going to face. And if it is going to be a focal seizures due to a transient event, say a neurocystic sarcosis, when it goes out of the body, it cannot even if it a tiny scar, or a transient event like a head injury or a CVT, which are transient things, so they are not going to persist for a long. But syndromic epilepsies are something very important. And always when we look at the classifications, structural stands first, and genetic and infections, metabolic, and nowadays the immune etiologies is coming up, but still 30% may be idiopathic. It's already discussed. And how we diagnose epilepsy? Everyone thinks about the modern gadgets. When we say, when we talk in the forum, everyone talks about the PET, MEG, and all. But the best diagnosis comes from the history. So what is more important is, and even can last even less than a fraction of a second. The baby just transiently withdrawn, and then baby will get back to normal. The child will get back to normal. In schools, it becomes very difficult. A transient withdrawal from the environment. Even the friends, the teachers find it very difficult to identify what is happening with him for a few fraction of seconds. He was not with us. He was withdrawn from the environment. But sometimes the seizures will be very evident. So they will have a tonic neck posturing, uprolling eyeball, drooling of saliva, tongue bite, twitching, urination, and a lot of automatisms, slim automatisms that will be evident. So when the teacher should be taught to identify epilepsies in every school. So most seizures tend to happen at the school. So the teacher must be able to identify. The awareness should include training up, or training or teaching the teachers to identify seizures, even an absence or something, they should be identified early. The history will also tell about the prognosis also. And when they come to a neurologist, a physical examination is also very important. A neurocutaneous marker or a neurofibroma, it tells what is happening internally without a scan. So, and also an EEG, which will tell us EEG is called the language of the brain. So EEG is recording the electrical activity over the scalp with the help of the machine. So a routine EEG can tell a lot of information. It's not most of the time it can be normal, but it doesn't rules out epilepsy. But it is important to do an EEG. And sometimes EEGs may tell or may not tell where the focus is. But in such cases, we need to dig more, admit them, do an overnight EEG. Some epileptic events tend to occur only during the nights, during daytime, especially when the kid goes to sleep. The epileptic for the brain behaves completely different. All sort of abnormal electrical activities will be there. But the moment kid awake from, in awake state, EEG looks completely normal. So when you do a routine EEG, it may not be sufficient to diagnose it. So dig on, and the history should make you to think of more seizures if parentals, if the seizure occurs only during sleep. Do a long-term EEG monitoring overnight. Do the recording. Every recording should have a component of sleep and awake, even if it is going to be a routine. Suppose if they find that the child doesn't sleep when it wants, make them sleep deprived. Wake the child up and bring them early. Take the first appointment. So the child will be deprived of sleep. As soon as we connect the wires and put them on the bed, they will have a sleep component also. And the EEG will tell us a smooth appearing pattern indicates a normal. But when a giant wave suddenly appears, this is something abnormal, and it is generalized. Identifying generalized and focals, the EEG helps us a lot. And most of the times, even though it is generalized, when we go through it, few seconds before, a sparking will be there, and then followed by this generalized. So they are focal in onset, but getting generalized. So that changes the line of management. So EEG is a simple bedside investigations. Of course, it's cost effective, but it gives a lot of information. Whether it is a pseudo seizures or it is a real seizures, everything can be made a diagnosis. Some kids has been diagnosed with pseudo seizures. For many years, they will be on anti-epileptic. When we connect the EEG and do a suggestion therapy, the child will have seizure-like movements, but the EEG will be running normal on the background. This helps in easy diagnosis. So a simple bedside will help in making the diagnosis. When the simple method doesn't work, we need to have an epilepsy monitoring unit. So what is the difference here is they get admitted. The patient will get admitted. They will be continuously monitored. And in some cases, we try to reduce the medicines gradually, and we provoke an event. So under a guarded situations, an intensivist will be there to manage even if the patient have a seizures, or like even if the patient can have a status also. So we have a strong backup team to do an epilepsy monitoring unit. The 24/7 someone will be with that, and the seizures can be captured. Capturing an event is very important, because if it is going to be medically refractory, we need to localize from the history and the EEG where it is. Then only you can correlate with all advanced investigations further, and you can understand when we do any advanced like stereo EEG. Stereo EEG is putting electrodes into the brain and then looking for the spikes. So, and also like brain doesn't works like hubs, so the hubs are interconnected, and a wave can transmit in any directions. It's not like if it is this focus, it can go anywhere. Identifying the connectonomics, how the hubs are connected, is also important. Stereo EEG can help in it. So epilepsy monitoring units is something, the next step in making the diagnosis of epilepsy. And sometimes it's not possible. Nobody wants to get admit nowadays, so they want an OPD based. Holter, no need to get admit. They do it on OPD basis. The same way, nowadays we do have software gadgets where the kid can wear around the clock, and it keeps monitoring, and also it helps whenever the child or an epileptic patient had an event, sends an immediate alert to the family as well as the caretaker. So they know that there is a seizure event, and then they can rush or treat, or they can do the first aid. First aid is very important, and treating the epilepsy at the point in times is very important, because it prevents the epileptic patients from entering status epilepticus, which is continuous seizures. So stop the first attack. It is very important right away. So nowadays the softwares also helps in identifying this. And if all these tests fails, then need to find out where it is coming out. There comes your stereo EEG. Stereo EEG is like putting electrodes deep into the brain, and then we can record all the activities right from the point of origin. So wherever the epileptic focus is there, we can get the real abnormal electrical patterns from there, and it also helps in understanding in what direction it is spreading also. That can be done. And also, like when you compute with your softwares and the MRIs, it clearly tells us this is the epileptic zone, which is the abnormal area, and it also helps in identifying mirror focus. It means over a period of time, if the right temporal lobe is the focus over a period of time, the left will also become a focus. It's called as a mirror focus. So it also helps in identifying is there any other zones. And sometimes if the patient had multiple seizure semiology, sometimes it is GTCS, sometimes it is automatism, sometimes it behaves differently, than using a cortical stimulator will help, stimulating the lead inside the brain will mimic exactly the same event that appears during the child. And this gives a lot of information, not only for in medical management, but it is very useful in surgical management, helps the surgeon in identifying where is the culprit and its directions and resections, and it helps in planning the surgery also. And when it comes to the medical management, 70% of the patients with epilepsy will definitely respond to medicines. And thanks to the research. So with the research, these are the old medications, so we call it as first generations, there is second generations and third generation. With the help of third generation, what was considered before of 32 responder rates increases. With the third generation, with the new medications, the response is really good. So previously, there was only one medicine, which is like phenobarbital, which is it's contraindicated myoclonic, but there was no choice. Phenytoin, only phenobarbital. These are the only two older medications. We have to manage epilepsy. But within a span of time, there is a sudden rise, and a lot of new medications are now available. With the help of new medicines, we get 63% of seizure-free intervals. And how we treat. So the classic method is called as trial and error. Identify the type of seizure, start with single medicines, try whether the patient is getting improvement. If it gets improvement, leave them off. Choose a soft medicine. Levetiracetam, choose a soft medicine, brivaracetam, put them for the first seizures. Try, if the patient doesn't have a seizure, continue with the simple medication with lesser side effects. Do not complicate. This is called the trial and error method. But what is coming up next? What is the future, or what is the trend now? Is a personalized treatment. Most of our Asians are genetically resistant for medicines. So they may not respond simply. And there is this trial and error methods. It's not going to be the way forward. So we do a genetic test to identify whether there are polymorphisms, whether the patient is having a gene which is resistant for medicines, and we correlate with EEG and all the methods that are available with us to identify whether this patient will respond to the medications or not. All these informations we can get, and the treatment is going to be personalized, which helps in managing them very effectively. And there are multiple ways to identify and treat it. When medical management fails, and it's not the end of the story. So this is the graph. Like when try drug 1, then 47% become seizure free. Try drug 2, again 13%, and finally what we left with is the 36% of the patients who got an uncontrolled seizures. For this, there is a lot of surgeries. There's a lot of newer methods of neurostimulation and neuromodulation, like deep brain stimulation, vagal stimulations, and all, like without touching the brain. Now vagal nerve stimulation is a new gift which is promising and upcoming, and our teams is going to talk about it. And what is foremost important is treating epilepsy medically is important to prevent a status. A status can kill anyone. It's not sure that we cannot revert them sometimes. Sometimes they go into tracheostomy, this hypoxic states, and then they landed up in a permanent disability state. So treating epilepsy is very, very important. The first and foremost is to prevent a status epilepticus. And I thank for the nice opportunity. And one more word is drug-resistant epilepsy is something which is coming up, but again, look into the compliance of the patients. The patients check again and again. Some patients will promise that I am taking tablets, but they may not take tablets. So drug-resistant epilepsy has to be taken with a pinch of salt, and always we need to dig more history, and then putting them on medicines to prevent a status, and that helps them. So I thank sir for this initiative, and I call up my colleague, Dr. Satya, to talk about status epilepticus and its management. Thank you.
Good evening all. Status epilepticus, it's a neurological emergency requiring an immediate attention and to prevent the morbidity and mortality. So before moving on to the management of status epilepticus, I wanted to define some phase what a status epilepticus. According to the Neurocritical Care Society 2012 guidelines, they have defined status epilepticus as 5 minutes or more of continuous clinical or electrographic seizure activity, or a recurrent seizure activity without coming to the baseline between the seizures. So this status epilepticus consists of some categories are there, like convulsive, non-convulsive, focal motor, myoclonic, refractory, malignant, or superrefractory. So in convulsive status epilepticus, starting with the seizure activity, there will be a generalized tonic-clonic seizures with mental status impairment. Whereas in non-convulsive status epilepticus, you can identify the patient has seizure activity only on EEG, and they will not have any tonic-clonic movements. And your focal motor is nothing but they'll have a refractory motor activity on a limb, or the myoclonic, as we commonly see in patients like hypoxic ischemic encephalopathy, the group of muscle activity will be there on one side of the body. Refractory status epilepticus, the above epilepticus what I have mentioned till now, like convulsive or non-convulsive, we have medications like benzodiazepines and the second line of drugs like anti-epileptic drugs. And usually these categories, they respond to those type of drugs. Then what is refractory? If the seizure activity doesn't subside even with the adequate dose of benzodiazepines or the second line of drugs, then the patient fits into the category of refractory. 40% of the status epilepticus comes under this category, refractory. So the predictors, can we predict them? Which patient will land up in refractory? Yes, there are few conditions like encephalitis, some non-structural causes like hypoxic ischemic encephalopathy, or a delayed diagnosis and treatment of any epilepsy will land up in refractory status epilepticus. So how do we go ahead? The next line of drugs like anesthetic drugs come into place for this category. Good. What do we do if they don't respond even to those anesthetic drugs? So those patients come under the category of malignant or super refractory. 20% of refractory status epilepticus comes under this malignant or super refractory. So how are we going to treat these cases? Yeah, we have these anti-epileptic drugs. Give a combination of drugs like anti-epileptic drugs with the anesthetic drugs. What to do if that doesn't cure? I stop the seizures. We'll move on. We'll see it in the treatment pathway of what are the other ways. Before moving on to that, let's see about the clinical features. A patient who ends up in status epilepticus has a compensated phase and a decompensated phase. Not all patients will land up in the decompensated phase, provided we intervene at the earliest and the patients, it's a reversible cause and it ends earlier. Of course, they may stop with the compensatory phase. The compensatory phase is due to the sympathetic drive, where there is an increase in cardiac output, blood pressures, respiratory rates, and increase in blood lactate levels, because there will be a lot of seizure activity, your muscle breakdown, all those things will be there. If it ends with this phase, it's good. If not, if it moves on, it goes to the decompensated phase, where there is a homeostasis breakdown, where the patient will land up in cardiovascular collapse, electrolyte imbalance, rhabdomyolysis, your tubular necrosis, and your metabolic abnormalities, hypothermia, and finally you have a raised ICP and cerebral edema. Right? Okay, what's the aim of mind in, what is the role of us? So, as you all know, the primary aim would be to terminate the status epilepticus and of course prevention of seizure recurrence. At the same point of time, you shouldn't forget the management of the precipitating cause and also the complications, as I have said earlier, if the patient has landed up in the decompensated phase. So the primary goal of management would be aborting the seizure activity as rapidly as possible. But at the same point of time, we have to have the respiratory and the cardiovascular status under control. Okay? Right? So, before moving on, how are we going to treat a status epilepticus patient? I want to say some few words about our continuous EEG monitoring in ICU. So how is this going to help us? Because this EEG is usually required for the treatment of status epilepticus. That too, it should be initiated within an hour of status epilepticus onset if ongoing seizures are suspected. All these gadgets have come into role for us to prevent a patient from going from a compensated phase to a decompensated phase. And the duration of EEG monitoring should be at least 48 hours in patients in non-convulsive status, because you need a minimum time of 48 hours for us to diagnose that they are in status epilepticus. And this EEG monitoring, one is to diagnose and second is for us to titrate the medications, which we are going to see in our treatment pathway. So ideally, where is the indication for our EEG? As recent clinical seizures or status epilepticus without return to baseline more than 10 minutes, or coma including the post-cardiac arrest, epileptiform activity or periodic discharges on initial 30 minutes of EEG, and suspended non-convulsive seizures in patients with altered mental status. So there should be an endpoint for this EEG monitoring when we are doing, when you are treating the patients. So if there is cessation of your non-convulsive seizures or diffuse beta activity and burst suppression of 8 to 12, in interval of 8 to 20 and complete suppression of EEG, then we can stop our EEG monitoring. So this is our treatment pathway for our status epilepticus. As I said to you earlier, the primary goal is to abort the seizures as early as possible, provided we have to keep the cardiovascular and respiratory status in our mind. So for that to happen, first you position the patient's head in such a way, keep the patient's airway open, provided you have your rapid sequence induction drugs next to the patient, so that if there is any impairment of oxygenation or ventilation, we need to intubate and ventilate the patient. Second, you have to supplement oxygen and initiate monitoring of your heart rate, respiratory rate, blood pressure, and oxygen saturation. Secure a good vascular access, and then you check your glucose level. Suppose you suspect the patient with a thiamine deficiency. Supplement the thiamine and then start your dextrose solution. So this is how we are going to start our treatment for status epilepticus. Of course, this happens for each and every patient who comes as an emergency, right? Now, we have secured an IV access. What if the patient, we are not able to secure in that emergency? We have IM midazolam is there, or a buccal or intranasal midazolam is there. You can use it in the initial shot for an initial seizure episode to stop it. Or if you have a good IV access, start with IV lorazepam. It's a drug of choice initially for a patient with status epilepticus. We choose it because it's a rapid and long-acting drug, and its anti-seizure activity is around 6 to 24 hours. And it's a safe drug, of course. And you leave it for 5 minutes, you observe. If the seizure doesn't stop, next, the second shot of lorazepam, the same dose you have to give. Again, wait for another 5 minutes. If the seizure doesn't subside, then you have to shift to your second line of drug, anti-epileptic drugs. You have phenytoin or phosphonitoin, sodium valproate, and levetiracetam, lacosamide. We have many of the, as Dr. Shankar has already said, we have many newer generation drugs which respond well, and they are also safe drugs. So we move on to the second line drugs in the prescribed dosages and wait for 20 minutes. So you waited for 20 minutes till the seizure continues. Give the second shot of those drugs in a lower dose. Still, the patient is not responding. So now the patient has gone and now we can name the patient as refractory status epilepticus. So we can use these anesthetic drugs like phenobarbital, pentobarbital, midazolam, propofol, all in bolus and infusion formats. And of course, when using these drugs, we know there will be a lot of hemodynamic changes and airway compromise will be there. So that's why we keep the patients in an ICU, and the monitoring, all gadgets are all inserted for the patient. And of course, we are also ready for intubating at any point of time. So now the patient is not responding even for the anesthetic drugs. So now the patient has landed in super refractory status. We are again trying with their anti-epileptic drugs and your anesthetic drugs combination, and you are moving for 24 hours. You are giving 24 hours time for you to see how is the patient responding. Of course, remember you have your EEG monitoring in place on the patient, and you are looking after how these drugs are helping out for their burst suppression. If after 24 hours the seizure is not getting subsided, meanwhile, all have in your mind, I already said to you about those precipitating causes like your CNS infections or any drug withdrawal syndrome or any drug toxicity, metabolic abnormalities, autoimmune conditions. All the workup will go simultaneously as you're trying to abort the seizure activity. So if you are able to make out any of the cause, any reversible cause, of course, the treatment has to get continued along with that. And next, if all these drugs have failed, still there is some emerging novel therapies have come, like ketamine, which is an NMDA receptor antagonist, or inhalational agents like isoflurane, desflurane. Using their entitled values, we can switch off. You can use it monitoring your EEG, whether the suppression is adequate or is it high or low. All those things we can monitor with this EEG monitoring, so we can give an adequate dose to them. And suppose we find the cause is autoimmune, you can use IV methylprednisolone or IV immunoglobulin. Now, if patient doesn't respond for all this, then you have these resective surgeries, as already has been said, some lobectomies or vagal nerve stimulation, and a lot of other things are there, which Dr. Sarkar sir will say in the later slides. And last is the ketogenic diet. We have heard of this ketogenic diet. I knew it was used for slimming, but when I was preparing for the slides for this, I saw it is very helpful too about the seizure activity. Like it's a low carb diet, and what happens is this induces the ketosis, and it suppresses the seizures by releasing the leptin. So this is how it acts. So we can try with the ketogenic diet. And finally, of course, hypothermia, which is always has a very neuroprotective role, of course, also in seizures. So this is how the management of status epilepticus in an ICU goes. So once, if the patient doesn't end up with respond to medications, then comes the role of the surgeons who will take over. So with this, I finish my talk. I thank for giving me this opportunity. Thank you.
Very good afternoon to one and all. So I'll be now taking you through the advanced diagnostic techniques with respect to the nuclear imaging techniques in those patients who are actually refractory to medical management, as was highlighted by Dr. Satya and Dr. Shankar. They form about 20 to 30% of cases, and these are the patients who actually are eventually surgical candidates. So for the surgery to be successful, what is important is accurate preoperative localization of the epileptogenic zone. MRI, as we all know, is the modality to identify a lesional cause of epilepsy. However, in about 20 to 50% of patients, the patients have a non-lesional cause, and it is in these cases where the functional neuroimaging in the form of ictal, interictal Spect and interictal PET. These are well-established techniques which help in the identification of the epileptic zone or the epileptogenic focus. And in these cases, the MRI is most often normal, or it may have some ambiguous findings like a subtle sclerosis or bilateral changes or atrophic changes, which may be discordant with the clinical semiology or the EEG findings. So brain Spect and brain PET. These are the two most important nuclear imaging techniques. Brain Spect, using technetium labeled tracers such as HMPO and ECD, they measure the regional cerebral blood flow in vivo. And FDG PET measures the cerebral metabolism. And these two parameters, the perfusion and the metabolism, they are closely coupled, and they correlate with the neuronal activity, with increased neuronal activity which is seen during the ictal phase and reduced activity seen during the interictal phase. So the brain Spect is typically done in ictal and interictal phases. The ictal phase is a bit technically challenging, as the tracer has to be injected within 20 seconds of the onset of the seizure. However, both the techniques provide complementary information, and the positive predictive value of an FDG PET is somewhere in the range between 70 to 90% in patients with temporal lobe epilepsy. So I'm going to take you through some real-time cases. 32-year-old female with temporal lobe epilepsy who has been suffering with intractable seizures since 14 years of age. Her MRI was normal. Her EEG and video EEG showed left-sided temporal spikes, and she had 3 complex partial seizures that were recorded, all of left temporal origin. And this is the FDG PET, which showed a discrete asymmetric marked hypometabolism involving the left temporal lobe with an anterior to posterior gradient. There was significantly higher asymmetric index anteriorly as compared to the posterior aspect of the temporal lobe. So since her PET findings were concordant with the clinical semiology and the video EEG pattern, she was planned for surgical resection. Co-registration of the PET with MRI further improves the lesion or the identification of the seizure onset zone, and this helps the surgeon in decision making, especially with certain quantitative softwares like SPM. So based on the PET findings, this patient had a petectomy. She had a left anterior temporal lobectomy with amygdalohippocampectomy, and post-operatively she had a very good outcome with significantly reduced frequency of her seizures in the first 3 months follow-up period, which subsequently reduced in the subsequent follow-up period. Now, in patients with temporal lobe epilepsy, a common finding on the PET is to find additional areas of hypometabolism. For example, in this patient with right temporal epilepsy, we can see additional areas of hypometabolism in the association areas like the basifrontal or the orbitofrontal cortex on the same side, as well as the ipsilateral insular cortex. And it can also be seen in the lateral temporal cortex, as seen in this patient with left temporal lobe epilepsy, extending over the left temporoparietal cortices. So what does this mean? This basically means that these areas of hypometabolism, which are in the extratemporal sites, represent the epileptogenic network or the pathway of seizure propagation from the onset site. And it is important to distinguish temporal lobe from temporal plus epilepsy, as patients with temporal plus epilepsy usually have a poor post-operative outcome. And knowledge about these areas actually helps the surgeon in planning his surgery. It helps him in guiding placement of the cortical electrodes so that intraoperative monitoring of the EEG can be done, and the focus, which shows the maximum discharges, can be resected out. Now, in patients with extratemporal lobe epilepsy, the reported sensitivity of FDG PET is slightly on the lower side, generally in the range of 55%. And this is because these seizures are generally of very short duration, lasting for a couple of seconds. And this results in rapid changes in the cerebral blood flow. And the incidence of extratemporal epilepsy is predominantly seen in the pediatric population, who usually have a normal or an inconclusive MRI. And the most common etiology is basically focal cortical dysplasia or heterotopias, which can be so subtle that they can be missed on MRI. And FDG PET can affect the surgical decision making in about 50 to 70% cases, and in some cases it can also alter the initial decision which was made based on the MRI or the EEG pattern. This is a 6-year-old male child with frontal lobe epilepsy who was born as a 32 weeks premature baby. He had onset of seizures since 2 years of age, and he used to have about 7 to 8 episodes per day, and each lasting for about 5 to 10 seconds. And all these episodes were predominantly nocturnal while asleep, few during the daytime, again while asleep. And clinically, he had a complex partial seizure of right hemispheric origin. And his MRI just showed right frontal atrophy. There wasn't any cortical thickening which was seen on MRI. And the video EEG showed a very large area of spikes coming from the right hemisphere, extending from the frontal to the parietotemporal region. And this is his FDG PET, which showed a discrete area of hypermetabolism involving the right anterior frontal cortex. And in addition, there were subtle changes which were seen in the basifrontal, subtle changes in the ipsilateral insular regions, and the right anterior temporal pole. So this child was planned for surgery under ECOG guidance, and he underwent an anterior frontal disconnection as intraoperative EEG monitoring showed that there were maximum spikes coming in from the prefrontal cortex. So yes, we can. As a team, we can all work together to provide cure and care to this group of patients who really need to be worked out for surgery. I'm really thankful to the Neurosciences Department for including our department in this initiative. Thank you very much, sir. And now I would like to invite Dr. Rishikesh Sarkar to give his talk on the surgical management of epilepsy. Thank you so much.
Right. Please don't get scared with the first slide. Neurosurgery has way lot changed than what it was before, and effective surgical solution is available for patients with epilepsy disorder. Surgery is reserved for only those patients who are not responding to medications, one medication, two medications, and still seizures are persisting. Then the role of surgeon comes. There are only three things as a neurosurgeon we do, and it's very simple to understand. First, we try to find it, where the seizures are coming from, which part of the brain that is coming from. Or once you find it, you burn it by various tools and gadgets which is available in armamentary of neurosurgeon, or you stun it, you deceive the brain, you buy something called a neuromodulation. Most of neurosurgeons' work is focused on finding it, and most importantly, finding it and localizing where this lesion is there and where the seizures are coming from. So the area in the circle, which is called as epileptogenic zone, is very, very important to find. And sometimes it is very easy, but in most of the cases it is challenging, and that's where the teamwork comes in the picture. We need to take help from neurophysiologist, neurologist, from nuclear medicine department to localize where this epileptogenic zone is, so that a surgery can be offered to remove this and achieve a cure. A patient who is the probable candidate for surgery undergoes a thorough evaluation by interdisciplinary team. As I mentioned, neurosurgeons, neurologists, neuropsych, an entire array of tests is required for PET scan, functional MRI scan, EEG and other things to understand what kind of epilepsy surgery will be required. First of all, whether it's required or not. Second, if yes, what kind of epilepsy surgery is required, and other things. If you classify the surgical procedures required for epilepsy, they can be either diagnostic, that means to find the epileptogenic zone, or they could be therapeutic. Diagnostic means placing electrodes deep in the brain to understand the seizure semiology and EEG changes, so that the seizure focus could be identified. While therapeutic means resecting or removing the focus which is responsible for the seizures. And neuromodulation means zapping the brain or stimulating the nerve so that the abnormal area does not discharge that way. Resective surgery means removing the area which is abnormal, and that involves lesionectomy. That means if there is a lesion which is identifiable on an MRI scan, to remove that lesion with the help of microsurgery or laser or ultrasound, whatever tool is available, or to disconnect the normal brain or adjacent brain from the abnormal brain. And there are again slew of procedures which are available. I'm not going to go and describe that in detail. Of late, over the last 10-15 years, neuromodulation is also coming in a big way. And particularly the vagal nerve stimulation, which is a non-invasive way, without even opening the head or touching the brain, to modulate the entire central nervous system so that the seizure intensity, the frequency, and the episodes come down drastically. The deep brain stimulation is another modality where deep electrodes are placed in the anterior nucleus of thalamus to control the seizures. Let's take a few examples. 38-year-old female presents with complex partial seizures, about 3 to 5 episodes per day, and such episodes are leading to fall and several hospitalization. She is on huge dose of anticonvulsants, and these anticonvulsants are causing problems. The MRI shows that is seen in the arrow, that the small area in the medial temporal lobe on the right side with some sclerosis or scarring in the normal language I can say. And as Dr. Sumati pointed out, PET scan shows, as the arrow shows that there is a hypometabolism in the medial temporal region. EEG also corresponds to abnormal spikes or epileptogenic zone arising in the medial temporal lobe on the right side. So in this case, there is something called as concordance. That means the patient's history, examination, EEG findings, PET findings, MRI findings, they are all falling in line to suggest that if we remove this medial temporal lobe lesion, the chances of surgical cure would be extremely high, and henceforth surgery is offered to this patient, which is called as right anterior temporal lobectomy and amygdalohippocampectomy, which is basically removing the medial part of the temporal lobe on the right side. This small surgical video. So all this is a human brain which you can see, and the retractor is on the temporal lobe, is gently placed so that the electrodes, the numbers are electrodes, the array of electrodes on the brain to identify which area is discharging abnormally. And once that area is identified and demarcated, you can see the portion is being removed now. That comes out. Then again, an ECG is done. Similar pattern is followed. Now this is again the deeper and deeper aspect of the temporal lobe that is being removed, making sure that we do not result a major deficit like language, memory. There are a lot of vessels which are there in this territory, especially on the medial side, that is gently dissected and it's taken out. So that's the apparatus, what we're calling burning. I think we can go to the next slide. You can stop this video. So post-surgery, this patient who was having 3 to 5 episodes of seizures every day on 3-4 medications, she becomes seizure-free 3 years in a row, and at the end of 3 years, the medication requirement also reduced to only a single medicine. Second case, a 6-month-old infant, just 6-month-old infant with history of hypoxia, and this infant has been having seizures since the 2nd day of birth, and so much so that about 5 to 6 times a day, resulting in infantile spasms associated with severe neurodevelopment decline. Clinically, patient also has got right-sided weakness complete. And slew of medicines have been tried, starting from valproate, levetiracetam, everything, ketogenic diet, nothing is working, everyday seizures. This is called as catastrophic epilepsy, and the MRI scan shows bilateral spikes from the occipitotemporal region, mainly from the left side. MRI shows malformed hemisphere. The entire left hemisphere is completely malformed and irritable, and this is giving rise to the characteristic EEG pattern. And this MRI pattern is called as left hemimegalencephaly, and surgically the irritable cortex, the entire cortex is disconnected from the subcortical structure, and this results into an excellent seizure control. 2 years since the surgery, the child remains completely seizure free. Not only that, beyond that, the child also made significant motor and cognitive gains. Last case, 37-year-old male presents with features of staring spells, generalized tonic-clonic seizures, gets once every month, causing severe disability, unemployed, social stigma, multiple medications tried, nothing's working, on a huge dose of anticonvulsants already. EEG does not show anything significant localizing, MRI scan is normal. What do we do such patients? Now that's where the vagal nerve stimulation comes in the picture. So zapping of the brain or zapping of the nerves essentially involves taking care of the circuits or giving a shock stimulus to the circuits which is responsible for causing seizure in particular cases where one cannot localize the source of the origin of seizures, in the cases like this. In children also, VNS offers an excellent therapy for controlling seizures and epilepsy, particularly cases like genetic generalized epilepsy like Lennox-Gastaut syndrome and other things. So this is an EEG pattern showing generalized activity, no localizing features in the EEG. And during VNS, which is a very simple straightforward surgery, does not involve opening of the skull or brain or nothing of that sort, a pacemaker kind of a device is inserted below the chest or collarbone, and the other part, the electrode, which stimulates the nerve, that is called as vagus nerve, is there in the neck. And that is connected, and with some play around with current, frequency, pulse width, etc., the best neuromodulation stimulation parameters are selected. And with this therapy, this patient became seizure free after 3 months after the implantation, and he was gradually weaned off the medications as well. And after 5 years, he was gainfully employed. Another area is finding up the epileptogenic zone and doing an invasive electrode recording. So this is called as the Robotic Stereotactic Eeg, where a neurosurgeon's expertise is required. As you can see here, there are multiple wires which are coming through the skull. And these small thin wires are placed deep within the brain, the guidance of something called as O-arm. And I'm very proud to say that we are going to acquire a similar device that will be there with us in the neurosurgery armamentarium next month. And we're able to do all high-end stereotactic EEG placement with that. I'm very grateful for management to equip us with that. And this will enable us to find out even those complicated cases where seizure localization is very, very difficult, to a very high degree of accuracy, so that our surgical results are on par with any international centers across the world. This is just a fusion image of CT and MRI and the various electrodes which are in the brain. So all these cases demonstrate that surgery is a very effective treatment for patients, those who are especially refractory to the medical treatment. However, most important task as a neurosurgeon is to find that correct candidate, and that's where the importance of the teamwork and collaboration comes, and that's why we are sitting over here today, discussing among ourselves the importance. There's a huge gap between the services available to cure the epilepsy. Dr. Bindu mentioned the reasons behind that huge gap, and as a team at MIOT, we will try to fill up that gap and propose the best possible solution for every single patient who comes with epilepsy and seizure. It may not be surgery. Not all cases require surgery, as Shankar said. 70 to 80% do not require surgery at all. And this can be effectively managed with medications alone, but they need some guidance about medications. So they are here sitting, all the experts. They will help you out with any patients who has got epilepsy and seizures. On that note, I'll stop over here, and maybe Dr. Bindu, you want to open the house for discussion?
Now, this is my opportunity to express my heartfelt gratitude to each and every one of you who had come here spending a Saturday afternoon despite the busy schedule that you are having. Thank you, MD, for giving an opportunity to portray the neuro team with our expertise to fight against epilepsy. I express my gratitude to the marketing team and the branding team who had arranged a platform within a very short period of time. I thank the IT department for helping us presenting our topics in a wonderful way. I thank all the speakers who had delivered a wonderful speech on this subject to enlighten all of you about epilepsy. Last but not the least, I again thank you, each and every one of you, for your full support and cooperation in hearing what we would like to say to enlighten the fight against epilepsy. This is a single step and the first steps towards the journey to fight epilepsy. Please do come hand in hand. Let us fight. Yes, we all can.